Okay, happy Monday, everyone. Good morning, good afternoon, good evening. Very excited to have everyone here today. This is Austin and I's one day a month to discuss, and we're super excited about it. And we're very happy to have Dan, who's going to be doing the scribing/teaching points, and Elena as well, who's helping out, and all the CP Solvers member. And we have Glenn from Botswana, who's going to be presenting a case today. And very excited to learn from everyone. Glenn, do you want to go ahead and introduce yourself to everybody, and then we can share the whiteboard and get started?
Okay. Good afternoon, everyone. My name is Thabiso Glenn Botsang. I'm from Botswana, Southern Africa. So I'm a medical student in the University of Botswana. I'm doing my fourth year at the moment. I'm interested in internal medicine, and I got to know this clinical problem solvers through Dr. Mark, who once visited us here. So I once saw a case where I was rotating in internal medicine here in Princess Marina Hospital, and I followed up the patient. But now I'm rotating in public health. That's what I'm doing currently. Yeah.
Awesome. Thanks so much, Glenn. So happy to have you. I'm so glad you got to interact with Mark, who was able to, introduce you to us. And yeah, really looking forward to it. So Dan, are you able to share the whiteboard?
Yeah.
Awesome.
Give me 1 second.
Glenn, what do you like to do outside of being a medical student?
Oh, okay. Outside medicine, I'm a big football fan, and I also sometimes play it. I follow Argentina and Manchester City at the moment. Another thing, I like traveling as well. It's one of the things I like. I'm a Messi fan, yeah.
I am also a Messi fan, and you're after Deborah's heart as a native Argentinian. Amazing,
Yeah.
amazing. Okay,
Can you guys see
so yeah, we can see that. Thanks so much, Dan. Okay, so Glenn, whenever you're ready, we can go ahead and you can give us the first aliquot.
Okay, so to start us off, we have a 53-year-old male who presented to A&E with bilateral leg swelling for 2 weeks, together with progressive abdominal distension for 1 year. Yeah.
Awesome. Is that where you like to stop for the first aliquot, Glenn?
Yeah, that's all.
Okay, excellent. Yeah, thanks so much. So I think we have a chief complaint here with bilateral leg swelling that we see not infrequently on CP solvers and really practically clinically as well. But this is accompanied, initially with what we thought is a subacute time course, but now it seems to be more chronic with a year or two of symptoms. So, if we think about the most common etiologies of lower extremity swelling, I think about a lot of the organs that can cause edema. So the heart, the lungs, the kidneys in particular. But then I also think about, obstruction, venous obstruction in particular, and the location of that can be more proximal or distal, depending on how things are going. And then hypoalbuminemia from multiple different causes leading to swelling. But if we layer that in with abdominal distension, we can build around the history of, abdominal distension, whether we think about the phases of matter of solid, liquid, and gas. And the combination of lower extremity swelling and the distension certainly makes me prioritize liquid, and in particular ascites. And it seems like the distension has started first, and the leg swelling seems to be sort of sequela of that. So, I think when something has, if we're going to say that these two symptoms are related, which for a clinical problem solving exercise is easiest to do, certainly we could separate them. But if we're going to say that they're together, the distension and this time course certainly makes me prioritize hepatic pathology. And portal hypertension in particular, with the leg swelling just being sort of an end sequelae of that. Because most of the cardiac pathologies people are going to present with earlier than 2 years, it would be very uncommon to have progressive heart failure for 2 years and not present with that. The kidneys can also, give you, it can be a longer time course, but typically I wouldn't associate with abdominal swelling be the first symptom of that unless there's significant organomegaly. So it's quite peculiar. But I think I would be loving to know, once we can confirm some of this, is there inflammatory signature disease? What other accompanying features are present? Or is there petechiae? Or has there been blood loss that has been visualized, or associated fatigue, or fevers, or lots of other things that we could add into that? But certainly, initially I would be building my differential probably around the swelling, because that's just a little bit easier. But if we layer in the distension that seems to have started first and seems to be sort of chronic progressive, then certainly I'm really interested in the liver, and would be going to the vitals in the exam to really get a hint of whether or not there's evidence of cirrhosis or whatnot. But yeah, those are my initial thoughts. And Austin, I would love to hear what you're thinking as well.
Yeah, not much to add. And I think the the curious thing here is like if we take a step back and we just solve abdominal distension, and then layer in the lower extremity edema, I think when I first saw the bilateral lower extremity edema, I couldn't really separate myself from the heart initially. But now if we say, well, actually, the primary problem is abdominal distension, how do we solve that? And I think from as you nicely laid out, the nice schema of solid, liquid, and gas is really, really helpful. And so which one of these things can really fit this time course particularly well? And I would say that, um, gas, probably if you had gas severe enough, if we're assuming that this is like truly chronic, like not like, hey, I had this situation and the abdominal distension comes and goes, and that aspect of it is chronic. If it's truly like every single day I experience the symptoms, then gas seems less likely, because otherwise probably the patient would have suffered some sort of terrible sequela at this point. If we go to the solid component, terrible, terrible abdominal distension to the point that it's growing and growing over a year to be solid. Seems like, it's possible with something that's like more indolent, but to think about, what could cause like a mass forming process. There could be like a benign tumor, there could be a malignant tumor, there could be an autoimmune disease, there could be infection. I think a lot of those things would probably have had consequences at this point, or the patient would have experienced like dysfunction related to that. And I guess we'll figure out if with more history if that comes into play. But to me, that seems a little bit, it's possible, but a little bit less probable. So that really leaves me in the liquid bucket, because liquid, you can really spread it to be more diffuse, right? So it's more forgiving in the sense that it can accumulate and accumulate and accumulate and not have any prominent dysfunction for that period of time. So I think from that perspective, that makes me worried that we're in the liquid bucket. And then we layer in lower extremity edema. And I think that speaks to, if there's a fluid problem in the belly, there could be a fluid problem everywhere. And so now if we layer back in, hey, how do I approach lower extremity edema? Same, all of those buckets. Which one of those things can start particularly prominently with lower, with abdominal distension? So the heart, I've seen many patients with heart failure over the years. I can't say I've seen that many that present with this time course with abdominal distension. Maybe if we learn that the patient has a history of heart failure, we'll start to clarify this a bit more. But someone has primarily right-sided dysfunction or has a pericardial issue, you certainly can have predominant abdominal distension more than lower extremity edema. But again, I think the time course for me makes that a lot less likely. So then that moves us to the kidneys, which you alluded to, which I think is also less likely in this case, which we can outline further in the future if we need to. But then that really prioritizes the liver, as you're saying. So how can we connect lower extremity edema to the liver with these separate time courses? So I think number one is that maybe the patient hasn't really noticed the lower extremity edema and it started to become more prominent. And that's an issue, because oftentimes if you see patients with cirrhosis, like you'll see them, it's most commonly you will have lower extremity edema if you have ascites. In fact, like the absence of lower extremity edema could suggest to you that maybe what's going on in the abdomen is not a hepatic cause of ascites, if that makes sense. So that makes me wonder, is there a compression phenomenon that's happening given the time course? Like, hey, fluid has built up. Maybe there's a reason this fluid is accumulating, and now that reason is causing a compression phenomenon. Or is there like a leak phenomenon that's happening in the sense that we're losing albumin, and so now it's gotten to the point that we're manifesting with lower extremity edema. So I'm curious to see where this goes, but I find the outline of how things progress to be really interesting. And so clarifying the time course, like, is this truly I've just been distended constantly during this time, or if it's intermittent, like, hey, I'm distended, I'm not distended, and there's like a waxing and waning type picture to this, I think that will really help us to frame what's going on. But Yeah, really excellent start, Alec. I don't know if you have any other things to layer on that. And sorry, my voice, it sounds horrendous.
No, that was excellent. So I think certainly we can build on that, and I think this just really, I guess, highlights again that tempo is queen. Tempo is everything, and that this really can help frame what we're doing. So, Glenn, do you want to give us a little bit more information?
Yes. Can move on to the history of the presenting complaint. So, the swelling started as the right unilateral swelling and then progressed to become bilateral. It's up to the knee level. Also reported minor pain, particularly to touch on the swelling. Did not report any alleviating or exacerbating factors to the swelling. Also, there was no reported fever or associated petechiae. Um, moving on to the review of systems. There's no reported cough, no shortness of breath, no abdominal pains, no yellowing of the skin. The urine is normal color yellow, no confusions, no nausea and vomiting. Essentially, there's nothing remarkable on the review of systems. And then moving on to the past medical history, is HIV positives for 10 years now. Is on treatment, has never defaulted treatment. He has no previous opportunistic infections, but on the control, he has the CD4 is 52. He has virological failure, but however, the viral load has been suppressed. Another thing on the medical history, yes, multiple self-limiting episodes of diarrhea and shortness of breath within the last year. So within that year, he had some episodes of shortness of breath and diarrhea, and he would seek help in the local clinic, and it will resolve just self-limiting. He doesn't have any surgical history. I hope I'm not too fast. Moving on to the drugs, he's on HIV medications. He's taking TAF ED, which is tenofovir, alafenamide, and emtricitabine. For the family history, yes, no family history of significant illnesses. Social history, he's a father of 6, unemployed, lives in Botswana, just in a village called Monapole nearby. On the health-related behaviors, he's a non-smoker and a non-drinker. On the allergies, there's no allergies at the moment. So that's it for the second aliquid.
Okay, wow. Yeah, no, thanks so much for all that rich information and for being mindful of the scribe as well, and like very excellent and structured presentation. So thanks so much. So yeah, a lot of rich information, Alec. Maybe I'll reflect on the first part where we learned a little bit more about the lower extremity swelling, and then a little bit about the review systems, and then I can leave the rest to you, and then we can, go back and forth if we need to. But as far as the legs go, I think we're getting the sense that the swelling, started on one side, went to the other side, and then started to progress, up to the knees with some tenderness to palpation. So what do I make of that? I think again, if I just ignore the time course right now and say, hey, someone presented to me with, hey, doc, I had one leg, and then Glenn was nice to tell us it was the right leg first and then the left leg. What would come to mind? I would say for most people, if you're going to notice lower extremity edema related to a central volume overload process, or even from liver disease, usually people will notice the left leg to be swollen first as opposed to the right leg. And the reason for that is basically everyone has anatomical May-Turner syndrome in a sense. So the only people that get May-Turner syndrome are those that have more pathologic compression of the iliac artery over the iliac vein. But because of that normal anatomy, most people are going to notice lower extremity edema on the left before it comes on the right. However, I haven't really met too many patients that notice one leg being swollen more than the other initially, unless there's truly like a unilateral process that happens, such as a clot. That would be the thing that we'd be worried about the most. In particular with this kind of like prolonged syndrome. So I think where my mind is at, like, okay, is there a clot that happened, and did this whatever underlying propensity this patient had to develop clot, then it progressed to the other side? I think that's a possibility. The other is that, hey, this patient just broke the rule and they have a systemic reason to have lower extremity edema. And now so they just so happen to have it on the right side, and now they're having it on the left side. And, I think that would make sense potentially. Infection is another consideration, but to develop like unilateral then bilateral lower extremity without any other rich review of systems, with Glenn, gave us a very nice review of systems, which we didn't really find anything else to suggest like this patient has an infection, though Alec will touch on how profoundly immunosuppressed the patient is. I think that maybe makes that a little bit less likely to me. The other thing is like, hey, we were invoking abdominal distension. We talked about maybe there could be some sort of compressive phenomenon that happened. Could there be something that grew more rapidly? Like, let's say we had a mass that grew and grew, and then it had an acute complication, like there was a bleed into it, and now we're having compression of the right iliac vein, and then the left iliac vein, but that seems also, highly unlikely, just given the lack of other like signature for that. I think we would have some other compressive phenomenon in the GI tract or the GU tract to have urinary symptoms or gastrointestinal symptoms. And so I think what this does for me is I'm worried about a local issue in the leg, and I'm in particular worried about a drainage issue in the form of a blood clot. But I'm open to the possibility of a compressive phenomenon. And again, if we believe the time course to be like true abdominal distension, no lower extremity edema, until most recently, then I think that's what I'm leaning on. If not, then probably this is just a reflection of a chronic process that has progressed, and now the patient in the last 2 weeks has just noticed the edema, and that's what brought them to care. And the abdominal distension didn't worry them so much, because it seems like this patient unfortunately has been experiencing recurrent episodes of an abdominal syndrome, potentially with shortness of breath, which I'll leave Alec to touch on. But maybe that's why they didn't pay particular attention to that until the edema came to mind. So a few thoughts there. I think otherwise I'll just leave that, the review systems, there's a lot of pertinent negatives here. There's not a lot of GI symptoms. Alec will comment on the episodes that the patient's been having, but there's no signature of rash. There's no signature of bleeding. There's no signature of in the lungs. There's no signature from a respiratory standpoint. There's no other liver signals as we could pick up on. And so I think that is really powerful, and something that we'll have to maybe reflect back on later as we learn more information. And this might just be over interpreting that a little bit, and maybe the patient, just because there's a lot of hectic things going on, though some of those things get downplayed, but that kind of really struck me as well. So yeah, Alec, I don't know what additional thoughts you have about that, and then also the rich past medical history.
No, thanks, Austin. I think that was excellent. Yeah, I'm also struck by the lack of other systemic signature of this disease. And then, it seems like as far as the presenting illness, the abdominal distension wasn't really commented on all that much. So I sort of wonder if that maybe has been intermittent, or is perhaps something that's less prominent. It seems like the edema is what the patient was reporting. So certainly going to have to try and explain that. But with the lack of fevers, the lack of dyspnea, the lack of other symptoms, it is quite peculiar. So as we go through the history, the HIV diagnosis certainly opens up a lot of things. It seems like the patient has been adherent to his therapy for the most part, and his viral load is suppressed, but the CD4 count hasn't really responded. So I don't know if the viral load has sort of on and off been elevated, or if the patient just hasn't responded in the way to the therapy that we had hoped. I think sometimes in the situation when the patient is acutely ill, the CD4 count can either be falsely elevated or falsely low, because it's just entirely dependent on what your leukocytes are doing. So sometimes in those situations, the CD4% can actually be more helpful. And a CD4% of 14% is roughly equal to a CD4 count of 200. And sometimes that stability, in that area can really speak to whether or not the patient's at risk for a certain opportunistic infection. So I would be interested to have that information. But if the CD4 count is 54, regardless of the viral load, I would be very concerned about the risk of opportunistic infections, but tracking that the patient hasn't had any virus before and has been adherent to therapy, but certainly places them in an immune compromised state that we need to be really cognizant of, not only for infections risk that this patient may have, but for patients that have chronic HIV, they're at high risk for malignancies and other things that we're going to have to keep in mind. The self-limiting episodes of diarrhea and dyspnea, it seems like they both come together, which is peculiar. So I don't know if the patient is just acquiring certain illnesses. As you can tell, Austin and I both have had viruses recently or currently have them. And so, shortness of breath and diarrhea aren't all that uncommon, that can come and go. But certainly in a patient that's this immunocompromised, you would have to be thinking about certain infections that could linger this long. But a lot of those enter through the lungs, and it seems like the patient doesn't have a significant pulmonary signature. So that's certainly interesting. And then I would also be really curious to know as well, these episodes of abdominal distension, do these correlate with the diarrhea? Is this only when the patient has distension, or do they seem to be separate? So it seems like that's not what the patient presented with. So hard to know exactly how much cognitive energy to put into that. But I think it's certainly a symptom that we're going to have to track. And if we don't really pick up anything else later on, maybe something we have to lean into a little bit more. But it certainly opens the gambit up to many infectious things or non-infectious things that HIV alone or the complications of which could develop. And then if we try to link the possibility of diarrhea and edema together, certainly the protein-losing enteropathy would be consideration, but it's not something I really want to jump to right now. So I think here we just have a patient with a subacute to chronic progressive sort of leaky syndrome with a background of HIV that's profoundly immunocompromised. So it's going to be interesting to build the differential around that. Oftentimes you need to really think about how the medications are affecting things as well. But tenofovir can cause RTA and renal problems and some other things, but I don't really think the medications are going to be culprit here. And then Botswana, I'd have to be looking up certain infections that are endemic there or things that the patient potentially could have been exposed to. It seems like they're not currently working, but if they have been exposed to animals or to other people that have been sick, are certainly things I would be tracking. So I think as far as next steps here, I think the exam is going to be really telling. What do the vitals look like? Do we see any stigmata of cirrhosis? How distended is the abdomen really? What does the edema look like? Or is there a rash the patient didn't note? Is there anything that we could pick up here? Because I think right now I'm still not confident with what problem I should be trying to solve. And so I think better defining that is going to be helpful going forward. But before we pass it back to Glenn, Austin, do you have any additional things to add?
No, that was great. And yeah, you certainly take care of patients similar to this. And so I'll be leaning on you later as we think about tests. But I think, as you mentioned, the differential diagnosis doesn't change. It just broadens significantly what's happening. And so depending on the resources that we would have, I think this would be a patient that we would be ordering a lot of tests just to understand what exactly is happening. Probably a lot of imaging, probably a lot of labs, in particular, a lot of infectious studies, and trying to just to get a sense of what's happening, because unfortunately they may not present in the same ways that we would think about, or it can just be really tricky with our sort of standard test to come up to an answer. So we'll see how things progress. I think reflecting real quick on the combination of diarrhea and shortness of breath, because I find that to be an interesting space. And so I think one way to think about it is is there a primary GI issue that's causing a signature in the lungs? And so I could think of tropical infections that could do that. For example, strongyloides, potentially, something like that. Is there a primary pulmonary issue that is causing GI symptoms? And so that one is a little bit harder for me to explain outside of more of a systemic illness, like a virus or community acquired pneumonia causing diarrhea as a consequence. I suppose we could invoke a person becoming bacteremic and having symptoms. But again, to suggest that they're self-limited will be really odd. And then to have, I guess the third possibility we'd have the patient is experiencing like a respiratory and a gastrointestinal syndrome simultaneously that's recurrent every single time. And that seems less likely. I think the way to link a diarrhea and shortness of breath is like, again, the abdominal distension, like the patient has worsening ascites or like bloating related to whatever abdominal issue they have, and that causes shortness of breath for whatever reason. So I guess we'll see. So the patient also has 6 children. I'm not sure how old the patient, like how old their patient's children are, but it's possible that if it's similar to the United States, that they're like constantly getting ill. So it would not be unheard of for them to just get recurrent illnesses related to their children over and over again, like us. So yeah, no, really interested. And Glenn, I'm excited to hear the next aliquot.
Okay, that was a good discussion there. Moving on to the next aliquot. So on examination, when I saw the patient, it was an old age man with a prominent abdominal distension, with a lower limb edema. It was grade 1 pitting up to the knee. He wasn't in apparent respiratory distress. I was not connected to any devices, any oxygen or whatever. On to the vitals now. The BP was 106 over 56 millimeters of mercury. The pulse was a bit elevated at 106 beats per minute. Was saturating at 93%. The respiratory rate was 17. The temperature was normal at 37 degrees Celsius. What else am I missing? Okay, now moving to the examination of systems. So starting with the abdominal exam. So, like I mentioned, there was abdominal distension. There was some telangiectasia and distended collateral abdominal veins. Actually, when I checked the distended abdominal veins, the venous flow was away from the umbilicus. There's also some tenderness for light and deep palpation on the epigastric abdominal region. I then measured the liver span was around 17 centimeters, which was elevated. Also, I palpated for the spleen, and there's some massive splenomegaly which crossed the midline. Also, there was some positive fluid renal test, but mostly at the epigastric region. Other systems, I couldn't pick up any remarkable finding on other systems, cardiovascular wise. I had normal S1, S2 with no VMRs, respiratory exam, the lungs were clear. Neurovascular wise, yes, he had no neurological deficits. Yeah, basically other systems, nothing abnormal was detected. Just lastly, to talk about the notable labs here. The hematology was HB of 8.5, had a MCV of 99, HCT of 18.9, had a white blood cell count of 3.01, with neutrophils 74%, lymphocytes 11.5%, monocytes 13.3%, and basophils 1.2%. I think that should be enough for this allocate.
Well, thanks so much, Glenn. A lot of rich information there. So Austin, I think I'll tackle the exam, and then maybe you can layer in any additional thoughts in the labs as well. So I think the blood pressure for a 53-year-old man is a little bit on the lower side. I'd be interested to know his BMI or if we have a baseline blood pressure. But I think that in the combination with the physical exam certainly makes me think about cirrhosis and particularly advanced cirrhosis. We see that the abdominal distension is very prominent, and Glenn gave us an amazing exam with telangiectasias, distended collateral veins, and it seems like he even did some ultrasound to see that the venous flow was away from the typical and the reversal of flow is very suggestive of portal hypertension. And the patient also has massive hepatosplenomegaly, which I'll probably invoke is from portal hypertension. But the hepatomegaly, if we're going to invoke cirrhosis, can be seen, but usually the liver is a little bit on the smaller side, depending on what's causing it. So that is something peculiar we'll have to see. And then the edema, although was initially part of the patient's presentation, I'm sort of just ignoring and really running towards the abdomen here to try and figure out what's causing the likely cirrhosis and the portal hypertension that we're seeing. I think also the oxygen saturation is very interesting. The patient doesn't seem to be particularly tachypnic, but 93% on room air isn't really normal. So I guess I would be very interested to see as well, is the patient just not able to expand their lungs very significantly because they have a lot of ascites? And I would be interested to know how the vitals were taken. Was the patient supine? Were they sitting up? Because that certainly could affect things. And cirrhosis in and of itself can cause many complications with your entire body, but in particular the pulmonary artery. So you can get hepatopulmonary syndrome, you can get portal pulmonary hypertension, and many other things. And I would be interested to know if the patient has JVD on exam, because that may shape somewhat what could be causing the hypoxia. And I think the tachycardia certainly something we're going to have to keep an eye on, and more of a marker of sort of the severity of the patient's disease, but it's not high enough or low enough to me right now to invest too much cognitive energy in and of itself. And yeah, I think at this point we really have to figure out why the patient has such significant portal hypertension and then cirrhosis, which is a problem that we're solving. So we're going to have to start investigating etiologies regarding that, and whether that's infection related or non-infection related. And then, it seems like the patient has a history of HIV and has had a lot of touches, hopefully, with the healthcare system. So I would love to know how these labs look compared to prior. Like, has the patient always had some leukopenia? Has the patient always been this anemic? What's baseline? And then I think I may have missed the platelets, but that would be something that we'll have to track as well. But, I think there's a lot of features of the exam that are pointing us towards the liver. And then the next question is really clarifying the time course and then figuring out why. And that will involve some certain labs and likely imaging as well. But layering that in on the history of HIV will also be quite interesting. So yeah, Austin, those are my thoughts on the exam. What are your thoughts on the labs?
Yeah, amazing. And Glenn, do you happen to have the platelet count?
I'm sorry, I forgot to mention the platelets. It's also on the right side. It's 27.
27. Okay.
Opinion.
Perfect. Okay, thank you so much. Yeah, no, I think Alec, like you really touched on everything that I was thinking about as well. I think we're going to have to investigate the lungs in some way, shape, or form, just because we're seeing some signal towards them. And you come up with a reasonable hypothesis, but with how immunosuppressed this patient is, I don't think we're going to get away with not imaging the patient's lungs in some way, shape, or form. I think I'd love a CT scan, but we'll see what resources we have available to us. I think the other thing that stood out was the blood pressure, but also the pulse pressure itself, is a little bit wide. And I think in these exercises, I read into this like a little bit. The most common reason I see a pulse pressure in clinic was that the cuff was not put on the patient's arm correctly. So, but I think, that's like an artifact of how we practice here. And, I think there's a huge focus, appropriately so, on how to do a proper physical exam and check vitals. And so I think these are very, very reliable. But I think, that could speak to a distributive state like, liver disease itself. And then reflecting on the hepatosplenomegaly and, what seems to be evidence of chronic liver disease is that, there is a limited differential diagnosis for that, as you're mentioning, Alec. And it's really all about like infiltration in some way, shape, or form. And I think you can almost lean on the same type of framework that you use for pulmonary edema. I've never really had this, or not pulmonary edema, excuse me, like infiltrates in the lung. And so that would be like water blood, pus, cells, protein, or other molecules. But really, it's like water is the first thing you're going to think about because statistically, it's very common, and then it's also very easy to address for the most part. But given how long this has been going on, that makes it a little bit likely from my perspective. I think the other thing here that I'm running towards that we cannot escape from is the possibility of granulomas in the form of infection. And so I think even though we haven't seen other signs of infection, this is something that we're going to have to do, as we've seen in multiple recent VMRs, we're going to have to do a heck of a lot to convince ourselves that this is not infectious in some way, shape, or form. And we'll see how things go, but that's where my mind is going. As far as the pancytopenia, would not be inconceivable from a person with advanced liver disease to have pancytopenia. The slightly elevated MCV could either be related to the patient's medication or the liver disease, or reflect that why it's not as high as you might expect, a combination of iron deficiency in the form of bleeding in some way, shape, or form. So we have kind of like an overlap process that's happening. I think also, given right now we don't know the time course of the hemoglobin, probably it's chronic based off everything that's going on. But I think we also going to want to make sure that there isn't hemolysis at play. And there's so much hecticness happening that, there could be hemolysis. It's probably not like the primary thing that's happening to this patient, but, it's something that we'll want to investigate with the smear and the rest of the hemolytic labs, if we're able to, understanding that a haptoglobin may not be particularly useful in this scenario if the liver is not synthetically working particularly well. But that's really what stood out for the labs initially. I guess I wouldn't say I was surprised to see that. And if you see pancytopenia and splenomegaly, that's kind of what you would expect to see. And the differential itself didn't stand out to me too much either. But Alec, I don't know if you had any other comments before we let Glenn talk a bit more.
No, I think that was excellent. So yeah, Glenn, I would love to hear more.
Okay, moving on. Also, the retic count was 1.14%. The total protein was 57. Bilirubin 17.4, albumin 33.9. The calcium, magnesium, the CMP, calcium, magnesium, and phosphate was 2.12, 0.78, 3.8 respectively. All of them were normal. And then the liver function tests were normal or in the normal ranges. The INR was 1.26. Also did the APTT, which was 24.5. The lipid profile was normal also. Then we also did the acetic fluid. So from the acetic fluid, we measured the albumin and the seg, which is the serum acetic albumin gradient. So the seg was 1.3. The serum acetic albumin gradient 1.3. I also did gene expect on the acetic fluid, which was negative. We did schistosomal serology, which was negative as well. The vitamin B12 also was on the normal ranges. Other labs that we did, also did checked for any tumor markers. So alpha fetoprotein was normal at 1.16. We also have CA 19.9, which was normal at 5.1. ACE also, we checked for it, which was 23.1, was on the normal ranges. We also checked for anti-smooth muscle antibodies, which was negative. And we also checked for the hepatitis B surface antigen. It came out negative as well. Now moving on to the imaging. So For the imaging, we started with the CT abdo-pelvis. So the CT of the abdomen and pelvis confirmed the massive hepatosplenomegaly and the ascites. Also, there are some periportal inguinal lymphadenopathy, and there are some pocket of fluid in the hepatic vein. Another thing that we did was the OGD, which didn't reveal any abnormalities. Yes, I'll save the other information which for the last investigation, which for the last allocate.
Okay, very good. Thank you so much. And then I think because some of the units are a little bit different in the United States, how was the bilirubin high or was it normal, or how would you characterize the bilirubin?
Okay, the bilirubin was normal. The only abnormal thing was I think the reticulocyte count, 1.14%. Other thing, the total protein, the bilirubin, the albumin was normal, the CMP was normal, the LFTs I mentioned were all normal, the INR normal at 1.26, APTT normal at 24.5. So, and then I mentioned the SEG, which was at 1.3, which was another abnormal thing. And then other things that we did, the tests were negative, the gene expert, the schistosomal serology, hepatitis B surface antigen. Yeah.
Yeah, no, thank you so much for clarifying that. Yeah, okay, very good. So, yes, I'd say it's I guess am I surprised? I guess that's the question I'll ask myself. And you know, I think the answer is yes to a certain extent. I think the labs that I would typically see as abnormal are abnormal. So like, and that's really in the form of the CBC. And I think we've confirmed portal hypertension with an elevated SAG. There are a few caveats to that, but I think we have confirmed that just based off the imaging and the rest of the clinical picture. So what do I make of the fact that the liver doesn't seem to be terribly inflamed, or we're not seeing any obvious cholestasis or signs of infiltration in the form of like an elevated alk phos? I think that lowers my probability that some of those conditions that I was thinking about are at play, but it doesn't eliminate the possibility just because there's so much momentum towards those phenomena, and it would really greatly affect the patient and the management overall. So I'm not really sure it moves the needle so much. I think schistosomiasis was a great thought to think about for sure in the scenario, and it was curious that that was negative. The tumor markers also, it doesn't sound like there was a obvious mass seen on the imaging, but those are interesting pieces of information. That the fact that they're negative, they wouldn't necessarily be so helpful if they were positive, but the fact that they're negative is interesting. The hepatitis B surface antigen eliminates most likely that the patient has like prominent hepatitis B. Could certainly be surface antigen negative and have chronic hepatitis B, so it doesn't eliminate the possibility of having hepatitis B. But we're not seeing evidence of HCC, for example, which would be definitely a concern. And then the imaging, we saw evidence of massive hepatosplenomegaly. We see a comment of like the hepatic vein, one of the hepatic veins being particularly large and full of fluid, and then some periportal lymphadenopathy, which if I think through other causes of or patients I've seen that have hepatosplenomegaly. I can't recall like prominently seeing lymph nodes before. I think you certainly can have lymphadenopathy, like small lymphadenopathy related to a pressure or fluid phenomenon, like you can see in pulmonary edema in the chest, for example. But it stood out to me, especially in this particular host, that's something that could be signal to inflammation in some way, shape, or form. So I have to say, I'm not really sure how this helps me a whole lot. Of course, it eliminates like certain infectious possibilities, but I think we haven't exonerated infection yet. And so I'm still going to try to understand that as well. And then going back to the EGD, you know, well, it was a bit curious. We didn't see varices. So that was, I guess, an interesting twist. You know, sometimes they can be small. You might not see them. Does that speak to like where this portal hypertension is happening? Does that speak to maybe that that helps with localization? I'm not really sure. We're seeing like the recanalized umbilical vein. And so maybe that there's just been enough offloading in other places that we're not necessarily seeing varices. So yeah, Alec, you know, I'm a bit perplexed about what to do. And then so I think I'd like to challenge myself, and I'll give you some time to talk, and I'll think about like what would I do next from here to try to make progress about you know, what's going on with this patient. But what thoughts do you have?
No, I think that was excellent. I think it's a really peculiar space that I think I find myself in, because it seems like, you know, we have some evidence on the labs for portal hypertension, right? The profound, you know, thrombocytopenia, and the very significant splenomegaly that we see, right? But we see no evidence of that on the EGD. And then it seems like the synthetic parameters of the liver seem to overall be okay. The albumin seems to be okay. The INR and the coags are fine. And the SAG, it's sort of on the borderline, right? Usually greater than 1.1 is what we consider portal hypertension. Could this be a fake out from something else? If we had the protein on the acidic fluid, I think that would be interesting to know if it was elevated or if it was low. So I guess I'm sort of asking myself, you know, and I think the schistosomiasis is an excellent thought, but that causing non-cirrhotic portal hypertension, and correct me if I'm wrong, Austin, or anybody in the chat, but non-cirrhotic portal hypertension is usually like characterized by bleeding phenomenon, in particular like varices. And the absence of that, you know, is peculiar. So I think non-cirrhotic portal hypertension is less likely. But the sort of the massive hepatosplenomegaly seems out of proportion to the portal hypertension. And so I'm sort of wondering if there's something infiltrating the liver and the spleen that is chewing up in the liver in particular a lot of those cells, or if the patient could have extramedullary hematopoiesis or something else. And the lymphadenopathy is also peculiar. I mean, I take care of cirrhosis all the time. I don't see that many that have periportal lymphadenopathy for the most part. So I'd be thinking about things that would be infiltrating the liver. So sarcoid, they sent the ACE level, which has a lot of imperfections, but there isn't a lot of other signature otherwise of sarcoidosis. I think that's probably less likely. I think I would love chest imaging just to know if there's any signature there. Amyloid, I'm not getting the flavor of that. There's no severe renal involvement, neuropathy, other things. The patient does have chronic HIV, and so it could be at risk for chronic inflammatory syndrome, but it seems a little bit from like AA amyloid, for example, but that seems a little bit less likely. And then, hemochromatosis, while the patient is anemic and likely iron deficient, seems a little bit unlikely. So that really makes me think about lymphoma in particular. Lymphoma can really do anything. So it'd be something I'm considering, and with the patient's HIV, something as well that we would be a risk for. But before we consider any of those, like you had said really astutely, we need to exonerate infection. And I think just because for a predilection, like for any of the diseases that cause hepatosplenomegaly, usually would be the granulomatous ones, and they all love the lungs. They usually enter the body through that, besides like leishmaniasis and some of the other ones. But so I'd be very peculiar if there was anything there. Just completing out other etiologies of cirrhosis, because it seems like does the patient truly have cirrhosis? It seems like they do somewhat clinically, but the massive hepatosplenomegaly and the normal synthetic function, the lack of varices makes me want to question that. And I don't know if the patient could have telangiectasis just from the portal hypertension itself or from something else. Certainly seems like the portal hypertension is something that we're going to have to solve. And what's causing the liver and the spleen to be so big, I don't think we can just blame it on cirrhosis alone. And I'm going to have to figure out what's causing it. And then we need the other sort of basic etiologies. And so autoimmune hepatitis, we sent the anti-smooth muscle. It's an imperfect test, but it seems clinically that's probably less likely without any other liver chemistry abnormalities, but certainly can happen. And we think about alpha-1 antitrypsin and all the other stuff, but I agree that those are less likely. So, and just completing the hepatitis serologies, if there is, hepatitis C or hepatitis A or anything like that, probably less likely hepatitis A, but anything else that would come up there. So as far as as what to do next, I think I would be, oh, and just a comment, the gene expert, I think that's amazing. That just speaks you to the base rate of TB. I assume that's for TB in your country. Like in the US, when we think about it, it's like a big deal to like send it out and doing everything, but you're doing that automatically on the patient. And the PCR is pretty good, but it's not perfect. So also just because of TB's predilection to the lung, I would also just be really looking for the chest imaging to think about that as well. So I think as far as to make further diagnostic progress, I think from here, I would be interested to repeat the SAG, see if it stays that way. I would also be interested to look at the lungs. And then if we don't have any serologies that come back, in particular, probably infectious serologies, and certainly there are other autoimmune ones that we could consider, but I think those are less likely. I do wonder if there would be a role of a serum LDH in this patient, just to see if it's fairly high, it might point us towards lymphoma. But if those are all negative, then I think tissue would probably be the issue, and whether or not doing a liver biopsy would be something to consider. But I'm sort of struck at, there are certain things that fit my typical illness script for cirrhosis, but then there are some that are a little bit discordant. And could just be that the varices were small and were missed, or like maybe there was portal hypertensive gastropathy that wasn't commented upon, or maybe things shaped out in a different way. But I think I'm struck by the lymphadenopathy. I'm struck by the hepatomegaly. I'm struck by the disconnect between the severity of the portal hypertension we see and then the spared synthetic function of the liver. And the size certainly makes me wonder if there's something else that's infiltrating it, whether that could be infection or cancer. I feel like less likely autoimmune, but sort of hard to pin on other diagnoses at this point. But Austin, what are you thinking?
No, yeah, thanks so much for really making that key point. And I think the other thing that we've been sort of dancing around but weren't explicit about is just making sure that we're not missing a cardiac issue driving this. So making sure that if we're able to get an echo, that we do that just to look for any pleural or pericardial process, a right heart dysfunction, and could speak to the fact that there is not as much synthetic dysfunction as we would expect. And then we still haven't figured out the edema, at the lower extremity edema aspect of this yet necessarily. And then the last thing would just be like, okay, if we ignore the liver as the spleen as the cause of the pancytopenia, like does this suggest that there's a marrow infiltration process that's happening and explains, there's basically, something in the reticular endothelial system that's driving all of this. And again, I think in this particular host, like infection is something that we're just going to have to rule out. So TB, as you mentioned, like it can be difficult to diagnose and treat TB. So, something that we'll be really working hard on. Some of the viruses, I think the time course is a little bit too long for. I'm not sure what endemic fungal mycoses exist in Botswana, so I have to look into that. But and if that's negative, then, in malignancy would certainly be a concern. So how do we make progress? I think I want that echo. I want some more infectious testing. I want a picture of the chest if we're able to do that. And as far as like what tissue to get, I think would be really challenging. Like, I'm not really sure, like, if he has one of these episodes of diarrhea again, like maybe I do, do a colonoscopy and scope and try to get tissue there. Like, I'm not going to biopsy the spleen as we've talked about before, unless we feel like really good about it. The liver, I think could be interesting to do. The bone marrow, is that signal, is that noise? I think I'm a little tricked. We could send the abdominal fluid for cytology and send it for culture and everything, and maybe we'll get lucky, maybe we won't. It doesn't seem to be enhancing tissue to like biopsy. Maybe I'd probably talk to the radiologist and see if we can go after one of these lymph nodes. It seemed like to be a high risk area. Maybe we could do it endoscopically if that would make sense. But yeah, I guess I'm really struggling to know what to do, so I'd be asking for help at this point. But yeah, Glenn, tell us what happened.
Okay, that was a nice discussion there. So we are not able to do many of the investigations as we would like. But we did get the chest X-ray, which was normal, and then the acetic fluid cytology is still pending at the moment. And then the last investigation that I wanted to talk about is the bone marrow aspiration test. So it showed granulocytic hyperplasia with immature forms predominate with myeloblasts forming around 15% of the total nucleated cells. Monocytes and monocytes increased significantly. Also, eosinophils increased, showing prominent granules. So this is just the report that they wrote after the bone marrow aspiration test. But let me go to their conclusion. So the conclusion was that features suggestive of myeloproliferative neoplasm, are most likely chronic myeloid leukemia, but however, we'll need immunophenotyping to confirm it. So the bone marrow aspiration test was just suggesting the chronic myeloid leukemia under the myeloproliferative neoplasm. Yeah, that's the last investigation that we did.
Oh, wow. Thanks so much, Glenn. And so the next aliquot, you'll tell us what you think the diagnosis is. Is that right?
Yes. Our weekend diagnosis was basically what I just said about the chronic myeloid leukemia, and then we just planned on to manage from there, and just we didn't do any further investigations.
Wow, that's fascinating. So so this patient's like physical exam, and just to clarify, so it seems like you think that the extramedullary hematopoiesis caused such significant hepatosplenomegaly to lead to portal hypertension. Is that right? Or
Yeah, that's what I was thinking, but because you didn't do other extra investigation, maybe we could be missing something also.
wow, that's a fascinating case. I want to thank you so much for presenting this, and what an amazing workup you and your team did, and just so expertly presented. I wouldn't have known it was your first time. So I really hope you have other cases to share with us as well. And I'll have to do a lot of reading on extramedullary hematopoiesis and whether it can get bad enough to cause portal hypertension. That's something that would be new for me. But certainly the time course of like the slowly progressive, like could be in keeping with CML in particular. And then I just wonder with some of the early precursors that were in the bone marrow, I'm like, I would love to know if there, eventually if the patient was able to get a peripheral flow cytometry, like I think that would be, or in one on the bone marrow as well, that would be super helpful to whether or not there are multiple different processes going on here to explain that. But certainly have a lot of reasoning to do, and it was a really fun case to discuss. But Austin, what are your reflections?
Yeah, no, amazing. I think there's always a tension of like, I think it's not too challenging to find yourself in the space of like the reticuloendothelial system, which if you think about it, is just like what are the places that really filter blood particularly well. So you have your lymphatics, you have your bone marrow, you have um, the spleen and the liver. I think it's not too challenging to find yourself in that space, but then trying to solve the problem within that space is where it gets really tricky. And it really all depends on where you meet the patient, in their course. And I think that's a space I need to like learn more about and reflect on a bit more, because I said, hey, I'm not sure bone marrow biopsy is the right way to go, but they were able to make a pretty reasonable working hypothesis about what was happening with that test, and what would have happened if we had got the liver instead, or we would have to, I think it's speaks to like just not I don't have a good framework for approaching this, so it's just something I need to read more about. But yeah, thank you so much, Glenn, for the case. I really appreciate it. And any other reflections that you wanted to share?
Yeah, I just wanted to say that it was a very tricky case for us. Even with the specialist, like someone would order his or her own investigation, the new specialist come and change the investigation. It wasn't just a straightforward presentation of the myeloproliferative neoplasm, and at least we found something that we can attribute to the cause of the symptoms. And then one thing we did for the management, we just did symptomatic management, and then the patient went for splenectomy. He actually gone today. I didn't follow up if the patient managed to do it, but scheduled for splenectomy today, and I hope he did. And yeah, that's all.
Wow, thanks so much, Glenn. That's amazing. You guys did an awesome job taking care of this patient, and seems like it's a very difficult diagnosis to make. And I'm glad that he's getting the treatment that he needs. And thanks so much again for sharing. Hopefully, you got lots more cases to share. And yeah, I'd love to pass it to Dan to do the teaching points.
Yeah, that was incredible. That was I was just listening to how the case was progressing. I would have never guessed that this was all an underlying malignancy process that was driving all of these symptoms. So very, very cool case. I thought we can just start off broad and just kind of narrow our way down. So starting off with the basics, approaching the bilateral lower extremity edema. I think one of the classic ways we approach this is having multiple passes. So our first pass, we hit our three key organs: heart, lungs, kidneys. Heart, liver, kidneys, sorry. Second pass, we think about venous obstruction, other issues like hypoalbuminemia. And then beyond that, we move into abdominal distension. And so I think one of the schemas we talked a little about here is thinking things of solid, liquid, gas. In this particular case, the patient has bilateral lower extremity edema, and they have a very unique acute on chronic time course that favors more liquid as opposed to a solid or gas process. And I think that was a very, very interesting pickup, and just wanted to highlight that. From there, we approach unilateral swelling. One thing that I think was very cool, I've never really thought about it this way, but oftentimes patients can have kind of like a physiologic May-Turner effect. So, of course, the iliac vein can normally be compressed, and so sometimes it can just be something we physiologically see. But of course, always need to think about thrombosis. Other things we classically think about are, in the right patients, of course, cellulitis, gout, and of course, compression from some other process. Something else I thought was really cool is we talked about the distinction between CD4% and CD4 count. And I think this is such a valuable point. CD4% is often much more stable through the waves of infection and inflammation, whereas the number can actually fluctuate quite a bit. And so, especially in acute inflammatory or infectious processes like this case, the percent can actually be a lot more reliable. And, one of the metrics that I think is so helpful is a percent of 14 is equivalent to a CD4 count of around 200. And I think that was such a great line. I wanted to highlight that. Additionally, from there, we talked a little about infiltrative liver disease. And I think this is such a valuable differential to explore. So, we talked a little bit about the water, blood, pus, and similar to how we approach lung disease, but also thinking about granulomas and, of course, malignancy, which was a subtle foreshadowing to what the case ultimately was. And then finally, just summarizing it all out, looking at non-cirrhotic portal hypertension. One of the ways that we classically, or at least I like to organize it, is just anatomically. So prehepatic, intrahepatic, posthepatic. Prehepatic, again, we talked a little about thrombosis. Posthepatic, any kind of obstruction. And then finally, intrahepatic, there was a lot of great diagnoses in the chat. One of them that I just highlighted is the schistosomiasis. And then finally, I think the biggest learning point for me is that whenever I see hepatosplenomegaly, always think about other things beyond just my standard differential. So late stage progression of CML leading to severe extramedullary hematopoiesis, that itself could also be a contributing factor and something that's driving all of this. So yeah, I just want to thank you guys again. I mean, what an incredible rich case. Great job presenting. Great job with the discussion, and really look forward to doing this again with you guys.
Amazing job, Dan. Thanks so much, everybody. And I hope everybody has a great day. Take care.